Namaste.
Hi.
Charu, Archana, all good to see you.
Yeah, hello, sir.
Sneha.
Sir, namaste, sir.
Namaste.
Yes, I wish you soon join, as soon as you join. Yeah.
Yes.
So, CN sir is not joining because he's got very high grade fever and cough. We can go ahead and start the program. Over to you.
Sahiti?
Okay. Sahiti, you can
We
make
are
it
live now, sir. We are live now, sir.
Okay. So, good evening, delegates and participants. Thank you for joining Shield Connect. And I also welcome all the doctors who are connected on this platform for today's webinar. AMOX Medical Disorder Committee with Rajkot, Jamnagar, Junagadh, Kutch Bhuj Society presents the webinar for today's topic is GDM, and it is 2 ICOG credit points applied by AMOX office bearers. So let me introduce our MOC for the today's webinar, Dr. Charulata Bape ma'am. Ma'am is consultant obstetrician and endoscopic surgeon, director of GEMS Hospital and Endoscopy Center and Ashwin Hospital at Pune. Ma'am is also chairperson of Study on Female Breast Committee, FOXY. And ma'am is also honorable consultant at Dinanath Mangeshkar Hospital, Cloud9 Hospital in Pune. Ma'am has also won the Best Video Prize at IAG Hyderabad, presented numerous videos and presentations at national and international conferences. Ma'am is trustee at Bal Kalyan Sanstha Pune, committee member of GGFC Pune, recipient of Smita Job Award 2019, recently won the Women Entrepreneur Award through Rotary Pune and awarded the MS Signature International Award 2022 for being an amalgamation of academician and public health expert. So I am happy to hand over this session to Dr. Charulata ma'am. Thank you, ma'am.
Thank you so much for those kind words. I am a very tiny lamp in front of all these bright shining stars of FOXY and AMOX today, and it is indeed a pleasure today to be the MOC for today's webinar, which is organized by the AMOX Medical Disorders Committee in association with the Gujarat OB-GYN Societies of Bhuj, Junagadh, Rajkot, Kutch, and Jamnagar. So, Dr. Sneha, she just finished looking after the breast committee in such a fantastic way, and now she has already donned the mantle of a chairperson of the AMOX Medical Disorders Committee, and she is on a spree of webinars, physical meets, and so many other things. And today's webinar is a part of this entire thought of spreading knowledge everywhere. We could not have thought of a better topic than gestational diabetes mellitus. We all know that India is the capital of the world of diabetes, and we are all seeing such an increase in the number of GDM patients. So here we are together to learn and understand a little more about this topic from some amazing stalwarts in the presence of very gracious people like Dr. C.N. Purandare, who unfortunately could not join, but Dr. Rajendra Singh Pardesi, Dr. Deepak Bhagde, Dr. Sudhir Shah, Hema Devakar Madam, Preeti Madam, Archana Dwivedi, Kirtan, and all the other presidents and secretaries, along with all our delegates from Gujarat OB-GYN societies. May I request that we play the prayer so that we can virtually inaugurate this webinar in the presence of all our stalwarts. Can we have the prayer?
Just a second.
Yes, ma'am. 1 minute. Huh?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Let us move from darkness to light with the help of the Almighty's blessings. With that, we declare that this webinar has been virtually inaugurated, and I hand over the proceedings to Dr. Sneha Bhuyar, the chairperson of the AMOGS Medical Disorders Committee. This particular webinar has been blessed by our dear Dr. Rajendra Singh Pardesi sir, Sujata Dalvi madam, and the ICOG also, and we have got credit points for the same. Dr. Sneha, it is always a pleasure to introduce you, but I think I shall just say that you are my friend, philosopher, and guide. And coming from a place like Yavatmal, you have taken the breast committee to such great heights, and we can, see your aspirations for further posts. And we wish that you succeed and take our organization even more forward. Over to you, Dr. Sneha Bhuyar.
Yes, thank you so much, Dr. Charu. I always believe that, our work should speak for ourselves. So rather than the long introduction CV, I always prefer to stick to the task. So respected chief guest, Dr. C.N. Purandare sir, who just talked to me and he conveys his inability to join because he's having a high-grade fever. Guest of honor, respected Dr. Sudhir Shah sir and Dr. Deepak Bagre sir, my AMOGS President, respected Dr. Rajendra Singh Pardesi sir, Madam Sujata Dalvi, who will be joining short, Secretary of AMOGS, all the esteemed faculties, respected Madam Hema Divakar and Dr. Priti Kumar, our dear friends, all the presidents and secretaries of the societies of Jamnagar, Junagadh, Rajkot, Kutch Bhuj societies of Gujarat, esteemed faculties, panelists, chairperson, my dear conveners, Dr. Kirtan Vyas and Dr. Archana Dwivedi, who have helped me in design Charulata Bapai, and all the delegates here, I would like to extend a warm welcome to all of you. Friends, as Charu has said, I have just finished my press committee chairperson, and yes, the committee, people talk about what work can be done, right from breastfeeding, benign breast diseases to, breast cancer, awareness, screening, everything, and early detection has been, the programs have been organized right from adolescent to menopause and at all fronts, to the public, to the training of paramedics and sensitizing the foxes at all levels. But as a hardcore obstetrician and a passionate Foxian and Amogsian, I have always thought of, medical disorders and high-risk obstetrics as at the top. And sir, Dr. Rajendra Pardesi has given me this opportunity, and that's the very reason I'm taking all these medical disorders at all levels across India. And that's the very reason we are going with these programs throughout India. Thanks to sir once again. And once again, I welcome to all of you, and I would like to have sir's blessings for this program. So everybody knows Dr. Pardesi very well, and I just request him for his precious words of blessings. Over to you, sir.
Thank you, Sneha, for kind words. Good afternoon, everybody. Guest of honor, Dr. Sudhir Shah, sir, respected Dr. Deepak Bagade, sir, Dr. Sujata Dalvi, Dr. Lakshmi Sekande, Dr. Ashok Kumar, Dr. Priti Kumar, and Dr. Charu Bapai, chairpersons of FOXI. First, I wish to congratulate Dr. Sneha Bhuyar and 4 societies, that is Rajkot, Jamnagar, Junagadh, and Kutch Bhuj, for organizing such a nice webinar on GDM, because it's still a topic of discussion. And faculties are very nice and stalwarts faculties. Dr. Sneha Bhuyar has taken this drive to join in hands with Gujarat societies. And if Dr. Sneha, I will tell you, if Dr. Bagade and Dr. Sudhir Shah sir, they are with you, I think there will not be any problem to move forward in FOXI also. So I wish every success to Dr. Sneha Bhuyar for her future endeavor in FOXI. I wish every success to this webinar. I don't want to be in between you and scientific content. Let us move forward together for this academic feast. Thank you. Thank you so much. Thank you.
Thank you so much, sir. Thank you.
Thank you, Pardesi
Yes.
sir. And now it is my pleasant duty to introduce none other than Dr. Sudhir Shah sir, who is our guest of honor for today. Can I have sir's slide, please? Yeah, so this is the formal introduction, but to each every one of us, Dr. Sudhir Shah has been a fantastic friend, a great company for any trip, any get together. His enthusiasm for life is so visible, and it is always a pleasure to be in the company of you, Dr. Sudhir Shah sir. And over to your academic involvements, you're a senior gynecologist working at Manan IVF Hospital, Rajkot. You've been the former assistant professor, Government Hospital, Vadodara. You've been the author of a number of books, and you've done a lot of research as far as NDVH, short straight needle, is concerned. You've given Ahmedabad Society Origin at the SOGOC conference, and you've been a faculty at so many conferences. Over to you, Dr. Sudhir Shah, sir, to kindly give a few words of wisdom and bless this webinar.
Thank you, Dr. Charu, for very kind words. It's a matter of great pleasure for me today to be a part of this interesting webinar on GDM under the banner of Medical Disorder Committee of AMOGS, with the president of AMOGS, Dr. Rajendra Pardesi, over here. Unfortunately, we don't have a Dr. C.N. Purandare because of his ill health, but we have a program director, Sneha, senior national esteemed faculties like Dr. Hema Divakar, Dr. Kriti Kumar, the conveners, Dr. Archana and Dr. Kirtan, who are very close friends of mine and colleagues. And to the top, my dear friend, Dr. Charu, our today's coordinator, and my colleague, Dr. Deepak Bagde. He is Dr. Deepak Bagde, not Bagade. He never Bagade anybody. Sneha, as we all know, is a very dynamic Foxian from Maharashtra. She is a former chairperson of Breast Committee Foxy, present chairperson of Medical Disorder Committee at AMOGS. As said in her introduction, she has worked a lot for Breast Committee and also for cervical cancer awareness. And she is the recipient of many awards at various platforms. So I wish her and her team today all the best for the interesting webinar on JDM. A kind request to every one of you, and especially to my colleagues of Gujarat, to support What and Canvas for her in the Foxy, because she's contesting for vice president, and who better vice president would be than our great friend Sneha Goyal. My best wishes to all the faculties over here, and I hand over to you, Charu.
Thank you, sir. Thank you.
Thank you, sir. Thank you so much, sir, for your blessing.
Thank you very much.
Dr. Sneha, will you like to do the honors of introducing Dr. Bhagde, sir?
Yes, definitely. In fact, it is a pride and privilege for me to introduce Deepak sir, as I fondly call him, a great friend, philosopher, and guide for me. Sir is the past president of and past and head of department of the IMA as well. So lots to learn from you. Certainly, I would like to listen to you and have your blessing, sir. Dr. Deepak Bagde, over to you.
Am I okay? Am I audible now?
Oh,
Yes, sir.
Can you
Okay.
please unmute, sir? Please unmute.
Yeah, he's
I
on.
thought I.
Yes, yes, now we can hear you, sir.
Okay, fine. Those were wonderful words, but those are expected when there's a good friend around. Sneha has been a good friend since a very long time, since I've been associated with Foxy. And to see Charu, Archana, Rajendra, Sudhir, and rest of my friends from Gujarat is always a pleasure. And what a platform today it is on GDM, which is an obstetrician's delight when it comes to obstetrics. But yes, I'm sure Kriti Kumar is going to do justice as soon as I leave this thing. I mean, as soon as I finish my talk, a small talk, or probably just wishes for Sneha and the others. Preeti, are you there?
Yes, sir, I'm there.
Okay, Preeti, hi.
Hello, sir. Namaskar.
So, namaskar. So, she's another person who has done great work also in her work as a chairperson. But coming back to Sneha, Sneha, will be very happy to host you in Jamnagar and Rajkot again on 13th and 14th of this month. And would be a pleasure to see you personally on those days. And we are looking forward to that. As Sudhir said very rightly, she's a hard worker. In fact, people here, all of them are so hardworking that for me to even, attend a full webinar is an issue. Yes, conference I can attend, but webinar probably is an issue with me. So you'll have to excuse me as soon as I finish this thing. But anyway, Sneha, you are good and you've been good, and I'm sure as soon as your aspiration of getting a coveted post of vice president is not going to stop you going high further up also. We wish you all the best, and I'm sure the people of Gujarat love you, the gynecologists of the Gujarat love you, and going to really vie for your ambitions. All the best to you, and all the best to everyone here. Thank you very much. Thanks, Amox. Thanks, Neha, for getting us into this wonderful webinar.
So thank you so much, sir. Thank you so much for your blessings and your wholehearted support. Thank you, sir.
Thank you, Deepak,
Over
sir.
to you,
The blessings are always very important, precious for us.
Absolutely, so rightly said.
Thank you, Charu.
So with that, we conclude the small inauguration program of this particular webinar. And I take this opportunity to thank Dr. Rajendra Singh Pardeshi, sir, Dr. Sudhir Shah, sir, Dr. Deepak Bhagde, and all our other dignitaries and faculties who are here with us for this small program. And I hand over the proceedings to Dr. Kirtan Vyas for the scientific proceedings. Dr. Kirtan, over to you.
Thank you very much, madam. So good to see all stalwarts over here. And without wasting much time, we would go ahead with the academic sessions. As Dr. Neeta Sata madam was supposed to chair the session, but she's unfortunately stuck with a patient. So I would request Dr. Varsha Dhruv madam to chair the session for the first speech also. So I would request Dr. Varsha Dhruv madam. She is a senior practicing gynecologist at Rajkot, presently the president of Rajkot OG Society. She has worked extensively in remote areas of Gujarat, including the Savakundla, and she was a executive committee member of IEMA Rajkot as well as Rajkot OG Society for many years. And her area of interest is high-risk pregnancy and infertility. So I request Dr. Varsha Dhruv madam to please go ahead with the session.
Thank you, Kirtan bhai. Thank you for inviting me and for nice introduction. I'm very pleased to introduce Dr. Preeti Kumar. She is co-chair Maternal and Perinatal Committee, SAFO, chairperson Safe Motherhood Committee, FOXY, committee member, MEM Committee, AOFOG, professor and head of Department of OBGY, Narayan Institute of Medical Science, Kanpur, organizing secretary, UPCOJ 2023 Lucknow, AICOJ 2020 Lucknow, Gestosis 2019, IAGE 2018, NZYF 2017 Lucknow, Vice President Lucknow OBGY Society 2020-22, core member Prevention and Violence Against Women, Cell Foxy 2021-23, 2018-20, recipient of Padma Bhushan Kamlabai Hospet Award 2020-21, recipient of Foxy Mr. N.A. Pandit and Mrs. Selja Pandit Award 2020-21, Society Liaison Officer Foxy Figo PPH Project UP India 2020-23, awarded Woman Inspiration Award by Innerville Club 3rd July 22, recipient of Woman Achiever Award by Lucknow OBGY Society.
I think Dr. Varsha, it's enough of introduction. You can stop sharing.
Okay.
Yeah.
Okay.
So thank you so much for that kind introduction. And at the outset, first and foremost, high regards for Dr. Sudhir Shah, sir. Just to show you, sir, I'm still holding this book here.
Thank you.
And thank you for always encouraging and inspiring us and in every way possible. Dr. Deepak sir, Dr. Hema Divakar, I think she's the mentor and guide for many. Dr. CN sir, thank you so much. And after all, Dr. Rajendra Singh Pardesi sir, I think he was the first person in the Foxy to push me into Foxy. So thank you so much, Dr. Rajendra Singh sir. If he's not here, Sneha, please convey this message to him. So high regards to him. And Sneha, I'm sure that whatever responsibility is bestowed on your shoulders, you will discharge the duties very well. So best wishes for all your future endeavors. And now I'm going to share my screen on presentation. So is my slide visible?
Yeah.
Yeah. So is it visible now?
Yeah, ma'am.
So now,
Yes.
next 15 minutes, I'm going to speak on screening for GDM controversies to consensus. And I'm thankful to Sneha for giving me this opportunity. Of course, the AMOX team, the Medical Disorder Committee. So first and foremost, let us define what is gestational diabetes. It is a carbohydrate intolerance with recognition on onset during pregnancy, irrespective of the treatment with diet or insulin, whether or not condition persists after pregnancy. So now FIGO has recoined the word as hyperglycemia in pregnancy. Any glucose intolerance during pregnancy should be labeled as hyperglycemia in pregnancy. And we know that hyperglycemia in pregnancy is a major global health problem, and hyperglycemia is one of the most common medical conditions women encounter during pregnancy. And look at the burden. 1 in 6 live births occur to women with some form of hyperglycemia, and out of these, 84% of them are GDM. It is also important to understand that GDM plays a very crucial role in increasing the prevalence of diabetes and obesity, not only in the mother, but also in the offspring. So this is a quote by Dr. Shishya that GDM is mother of non-communicable diseases. Now I'll take you centuries back. This is in one of our mythology that when a life gets seeded in mother's womb, it's the age, deed, wealth, education, and death. They are all determined right there in the womb. And the same was reinforced by David Barker in 1938 to 2013, that the body's susceptibility to lifestyle diseases is all programmed intrauterine. So what is intrauterine programming? It is a process where the stimuli, maternal fuels, or stresses that occur at a critical or sensitive period of fetal development may permanently change structure, physiology, and metabolism, which predispose individuals to disease in adult life. And this is known as fetal origin of adult diseases. Again, this slide is very important to understand that exposure to a diabetic environment in utero is associated with increased occurrence of impaired glucose tolerance and defective insulin secretory response in adult offspring, which is independent of the genetic predisposition to type 2 diabetes mellitus. So that is important, that it is very, very important to diagnose and detect diabetes early in pregnancy if we want to save the NCDs in mother and in the offspring. GDM has its impact on maternal and child health. There are short-term and long-term impacts. These are the slides from FIGO's bulletin. And as we all know, there are short-term and long-term implications on the mother and the fetus. I'm not going into much of the detail. Now, FIGO recommends universal screening testing for all pregnant women, and they should be tested for hyperglycemia in pregnancy during pregnancy using one-step procedure. And this bulletin was released in 2015, and I'm very happy to share that Dr. Hema Divakar was also part of these guidelines which were made by FIGO. Now we have number of tests today, screening tests. There are WHO criteria, NICE criteria, there are ADA criteria, DIPSI criteria, Carpenter-Kushner criteria. Now, which criteria to adopt in our country? There is no international consensus regarding the timing of screening method and optimal cutoff points for diagnosis and intervention of GDM. The IADPSG criteria is the only outcome-based criteria. It has the ability to diagnose and treat GDM earlier, thereby reducing the fetal and maternal complications associated with GDM. This one-step method has an advantage of simplicity in execution, more patient-friendly, accurate in diagnosis, and it is more close to the international consensus. So these are all tests, and these are all cutoffs which have been given by various organizations. ACOG has its own cutoffs, IADPSG has its own cutoff, but in our country, what we need to follow. Which test is feasible in our country? Is it RBS, it is FBS, or 50-gram glucose challenge, or 75-gram glucose challenge, or any other test? The Government of India has given a clear guidelines that universal testing of all pregnant women using single-step procedure with 75-gram glucose in fasting or non-fasting state at first visit and to be repeated at 24 to 28 weeks of gestation. Now, these are Government of India guidelines, which clearly quotes that at least minimum you should do 2 tests, one at a very first visit and the second one at 24 to 28 weeks of gestation. Now, again, it is ideal to understand that it is very important to understand that we must do a third test at 32 weeks of gestation, because 1/3 of GDM are detected in the last trimester after 32 weeks. So please do not, if you have the facility, if you can do it, it is always advisable to do it at 32 weeks also. Again, I want to emphasize that Government of India quotes that you should do first at first trimester, the second one at 24 to 28 weeks. But ideally, if you can do it, you should do it at 32 weeks also. Now, National Government of India guidelines are that the testing of GDM is recommended twice during ANC. The first testing should be done during first antenatal contact as early as possible in the pregnancy. The second testing should be done at 24 to 28 weeks of pregnancy. If the first test is negative, it is important to ensure second test, as many pregnant women develop blood sugar intolerance during this 24 to 28 weeks of gestation. Moreover, only 1/3 of GDM positive women are detected during first trimester. If it could not be done during this time, then it can be done later on at 24 to 28 weeks of gestation. There should be at least a gap of 4 weeks between the 2 tests. The test to be conducted by all pregnant women, even if she comes late in the pregnancy of ANC care. And if she presents beyond 28 weeks, then only 1 test will suffice as a screening test. Now, again, I want to clear here that the screening and the testing are both the things are same in gestational diabetes when we talk about the Government of India DIPSI guidelines. 1 step 75-gram OGTT advantages are 3 times more pickup than with 2 tests, suitable for Indian settings, saves time, cost, and avoids repeated visits, and it reduces the repeated invasive sampling. So this has been awarded, accepted by the Government of India. FOXI and FIGO also recommends a single step test, whichever is feasible in our country. So DIPSI recommendations are that 1-step procedure, irrespective of previous meal, 75-gram oral glucose load to be given, and you should test the plasma glucose after 2 hours. It is simple, economical, and feasible method. And how to test, again, plasma glucometers are good enough to test the sugar levels. You need not to send these samples to lab. You should have the plasma calibrated glucometers, which can give you the ideal value. Again, it is important to understand that if the patient vomits within 30 minutes of taking glucose, the glucose has to be dissolved in 200 to 250 ml of water. It has to be taken in 5 minutes. If the patient vomits within 30 minutes, the test has to be repeated the second day with antiemetics. But if patient vomits after half an hour, then the same test will suffice. So you can take the same value even if the patient vomits after 30 minutes. It is important to understand these values. I've put these values, 4 values. If it is less than 120 milligram, the sugar levels are less than 120 milligram, it is considered as normal. Many of the times you will find that the blood sugar range between 120 to 130 milligram. This is gestational glucose intolerance, and you should always pay attention to these patients. You should give guide counseling to these patients, because otherwise they will land up in GDM much earlier as you expected at 28 weeks. Any value between 140 to 190 are GDM. More than 20 are most likely to be pre-existing diabetes, or they are frank diabetics who have been undetected earlier in the pregnancy and they have been diagnosed during this pregnancy. So these all values, tell you about the mode of treatment. Dr. Hema would be talking about their management. Which are the patients where you think that the only MNT would suffice? Which are the patients, like if the value is more than 200, these are less likely to respond to your oral medication. These are the patients who need your insulin therapy along with MNT and lifestyle modification. Now, coming to the role of HbA1c, many of us do have the query whether HbA1c is a test that can be done during pregnancy for screening or testing. There are a number of studies recently. I have quoted few of them here. This is a recent study from 2022, the role of first trimester HbA1 screening detection of diabetes. Now, let us see what this paper says. The first trimester HbA1c cannot replace OGTT for the diagnosis of GDM because of its insufficient sensitivity and specificity. However, women with higher first trimester HbA1c had a high chance risk of developing GDM incidence. Again, the cutoffs for HbA1c, which we were earlier taking as 6 or something between 6 and 6.5, is now brought down to 5.5 or 5.7. This is another study. This is a longitudinal changes in the relationship between the hemoglobin HbA1c in the pregnancy and the postpartum period. This paper is also recently published. It says that in pregnancy, OGTT and SMBG, self-monitoring of blood glucose, remains the primary tool used in diagnosis and monitoring of hyperglycemia. HbA1c is considered a less reliable marker for glycemia during gestation and often remains within the normal range in women with gestational diabetes. With HbA1c is not recommended as a tool for diagnosis of GDM, HbA1c is used by obstetric providers to screen for pre-existing diabetes only in early pregnancy. This is the recent publication from Harvard, from Massachusetts General Hospital. A large number of studies, they have quoted that HbA1c is accepted for screening of pre-existing diabetes only in early pregnancy. HbA1c is affected by conditions that alter the lifespan of RBC. And we know that Indian settings, in Indian pregnant women, most of them are anemic. Despite a Pradhan Mantri Anemia Mukta Bharat program, we are not able to bring down the anemia prevalence in our country. More than 50% of the pregnant women are anemic in our country. So pregnant women exhibit altered RBC kinetics, increased erythropoiesis and hemodilution, and therefore HbA1c is not a reliable tool for screening GDM. Now, coming few words about postpartum. Retesting of women is very important when we talk about the postpartum care. Besides your early detection of infection, breastfeeding, contraception, and other things, retesting of these women are very important. Now, which test to do in postpartum period, whether it is fasting, HbA1c, or 75-gram OGTT? It is WHO 75-gram OGTT is the ideal test. The catch here is because it is simple, doable, and evidence-based. Here you have to do a fasting sample again, and then load the patient with 75 gram. This is a difference between the single step test, which you do in pregnancy. You load a patient with 75 gram, irrespective of diet. Here you have to do a fasting sample, and then you do a 2-hour post 75 gram load. If the value of fasting is more than 126, these values are important. And if 2-hour 75 gram is more than 200, these are overt diabetics. These patients need to be sent to the endocrinologist or physician, and further monitoring should be done under their care. Now, if the values are between 100 to 125, and the postprandial is between post 75 gram is between 140 to 199, these are pre-diabetics, or you can say impaired glucose tolerance. So these are the patients who need a care, a diet, lifestyle modification, and definitely some form of insulin sensitizers or oral hypoglycemics. Now, when to call these patients? Depending on, there is no definite criteria, but patient may be on MNT, or she may be on oral hypoglycemics, or she may be on insulin. The first testing should be always be done after 72 hours of delivery. If she's on insulin, high doses, definitely she needs a regular monitoring immediately after delivery. But if she is on insulin, well controlled, then third day fasting postprandial is important for monitoring and bringing down the insulin levels. Once they are normal, then you have to call them. If everything is normal, then you have to call them after 6 weeks. Then the protocol is you need to call them after 6 months. And then every pregnant woman who had a hyperglycemia in pregnancy should be checked yearly thereafter. Now, this is a study which has clearly shown that the reality is only 34 to 73% come back for the postpartum screening. The rest all are lost somewhere. So these women are at a high risk of developing diabetes and NCDs early in the pregnancy, maybe 5 years down the line. These are other long-term complications that need to be checked if the patient is a case of hyperglycemia in pregnancy, because they have high chances of developing NCDs. Therefore, we talk about GDM and NCD break the nexus. Now, I'll share few slides on the project that we did Vistrit in Jharkhand. There were few challenges on the diagnosis, management, and follow-up. But since I'm talking only about the screening and the testing test, this project was done in private facilities, 30 private facilities. This was supported by USAID. This was FOXY project and done by Safe Motherhood Committee, FOXY, in the state of Jharkhand. We did this screening, we did the pre-training survey of all these healthcare workers. As you can see, they are holding a pre-training survey tool. These were all multiple choice questions, and they marked whatever they knew about the testing. Now look at this survey. Now the doctors did the different survey and the healthcare workers did this different survey, but both of them, the questions were almost the same. Only 50% of the doctors were aware of exact method of screening in our country. Though Government of India have given these guidelines long time back, but only 50% of the doctors were, they did mark that they were doing OGTT with single step test with 75 gram glucose. Rest all were doing random sugars, some were doing fasting, some were doing fasting and postprandial, some were doing HbA1c. So there were a lot of the disparity in their testing protocols. Only 56% were doing the correct method, using the correct method. Now look at this awareness survey of healthcare workers. Only 43% knew about the 75 gram glucose, and look at this. Only 35% were aware about the exact cutoff of 140 milligram. Now, most of the times the patient are in contact with the healthcare workers. So it's a prime duty to not only update our knowledge regarding the guidelines, but it is also a prime duty to update the guideline, the knowledge and the attitudes of the healthcare workers of the facility. So after the trainings, there had been marked improvement in all the facilities. And this was another challenge where the resource material, which 75 gram glucose you are using for the testing. As you can see, only 47 were using the anhydrous 75 gram. Rest all were using, some were using glucon C, some were using glucon D, some were using even sugars for the testing. चीनी घोल घोल के पिला रहे थे 75 ग्राम. तो ये इस तरह की टेस्टिंग का रिसोर्स मटेरियल का we got this data from the project Jharkhand. This was a huge coverage in the media in Jharkhand, and we got appreciation from USAID regarding this project, because this brought a huge change in the maternal care as far as the GDM was concerned. This was a Vistrit project, and I'm very happy to share, really thankful to Dr. Hema Divakar for initiating now Vistrit Kasoga in Karnataka. We are taking up 30 facilities on board, and we are expanding this to Karnataka society as well. So the last line I would like to read out loud and clear: a man with a watch knows what time it is. A man with 2 watches is never sure what the time is. So we all need to follow a single step test and test as early as possible, and try to find out hyperglycemia, because we need to focus on future, because everything starts in utero. I always quote the lines from Dr. Shisheya, because it all starts in utero. So thank you so much for patient hearing. If there are any questions, I would be happy to answer those questions.
Thank you, ma'am. Thank you for covering all the aspects of screening of hyperglycemia in pregnancy. Our next speaker is Dr. Hema Divakar. She is Medical Director, Divakar Specialty Hospital, Senior Consultant,
Yes, sir.
OBGYN. Yeah. CEO and Chairman Artist, Chair of Well Woman Healthcare Committee at FIGO, Dean KCOG, President DIPSI, Vice President AHPI, past President of FOXY 2013, past Vice Chair for FIGO PNCD Committee, an advocate for delivering quality healthcare convener and Manyata, an opinion leader and influence for social and legal issues relating to women's health, awards and recognitions: FIGO Women Achiever Award 2015, Global Asian of the Year 2018, CME Excellence Award for Artist, Next Brands Award for Artists of a CSR Times Award, CSR Impact Award for Divakar Service Test. Dr. Hema ma'am.
Thank you so much. Namaskar, everyone. And today's deliberation brings forth G for GDM, G for Gujarat, B for Bhuyar, and B, the best. S for Sneha, and S also for sweet. And now what are we waiting for? S for success. Wish you all the very best, Sneha. And I do hope that you will carry the great dedication, commitment, leadership far, far ahead for the well-being of girls and women in this great country. So the first step, the Pehla Kadam, has been taken by none other than my very beloved Preeti, who is always the first to respond to the call of distress, of how to reach the last mile, however hard the path is to walk, just let's do it. That is her determination and the mantra. And usually and always, in my experience, when you join hands with Preeti, we are sure to move far, far ahead. That is a great source of inspiration and relief and dependability and credibility in itself for many, many champions across the country and past, present, and future leadership of Foxy. To all my beloved friends whom I see here on the screen, thank you for always, always doing so much beyond what is expected from you. I think, Foxy is one, sometimes I call it a crazy organization because all of us have that element of craziness to just keep doing, whatever is needed to be done. We are also having the courage to fail, learn our lessons, make course corrections, and get up again and move in the right direction. So the reason why all of these issues such as hypertension in pregnancy, hyperglycemia in pregnancy, obesity in pregnancy, all of these sow the seed for the future NCDs. The tsunami of the number of cases of diabetes we're having in the country, yes, it all begins in utero. The baby which was programmed in the mother, who was not taken care appropriately during her pregnancy, her sugars were never tested, never monitored, how this baby will behave and how she will behave in the years to come. Short term, we as obstetricians are worried whether it will be macrosomic, whether I'll have a hell during delivery, better to post her for C-section. Maybe she'll have polyhydramnios in preterm birth. Maybe this mother will get into complications and I have to lean on the physicians and diabetologists. Lot of issues till we sail through the pregnancy with her, with all the difficulties. Take home mother, take home baby, all well. But in this situation, we cannot forget both of them. Because as Preeti said, she has to come back not only in 6 weeks, but every single year for the rest of her life. Because we want to catch her. If she develops type 2 diabetes, then we need to detect that early and do the best for her at the earliest possible. The baby, this is an offspring of a GDM mother. What can happen to that? The pediatrician should also be aware that this baby has perhaps been born macrosomic. It will be childhood obesity, be early onset type 2 diabetes. So the entire generation next will be goofed up if we as obstetricians do not take the responsibility for not only 2 lives, but 2 generations in the matters of comorbidities such as hypertension and hyperglycemia. So what is the practical approach? You have done the first job of universal testing and detection. You have detected it very early. Sugars are not way too high. You can give an ample chance for diet and exercise, the lifestyle which can manage. But, dear friends, the practical approach, you tell her proteins, carbohydrates, calories, this, that, and the other, the patient, first of all, is frightened because you told her something to do with diabetes. Then you told her this, that, this complications will occur. Then the whole family is looking at her with, great sense of, suspicion ki iska pehle se kuch tha ke God knows what is now happening to her. How at this age all this happened? And they're not really receptive if you just shoo them off to a dietitian who will again, it's a new person that the patient is dealing with. So what could be and should be your practical approach? First of all, please use the FIGO nutrition checklist. It's just got 4 little points there. It takes 2 to 5 minutes to fill the checklist. It'll give you a fair idea of the dietary recall. A South Indian like me is sitting in front of a doctor, and the doctor is telling it will be very good for you to eat fish and red meat and all. How am I to feel? Okay, so first you take vegetarian, non-vegetarian, eating eggs, not eating eggs. What does she have normally in her daily diet chart? So dietary recall is very, very important. Then you can guide her further. You have to tell her that some food substances that you take, they will quickly convert into 100% sugars. And that is bad for you because your body has already proven that it cannot handle sugars. Okay, carbohydrate is one such foodstuff. And if you eat a lot of starchy vegetables like potatoes and corns, for example, and cake and pastries and frank sweets like gulab jamun. Now, rasmalai is going to be the treat by Sneha when she wins the elections, which Preeti has already given her menu for that. So, it's such stuff if this person eats, suddenly the sugar shoots up. The sugar shoots up, the body cannot handle it. So you have to tell her that whatever carbohydrate, rice and wheat both have carbohydrates, she should cut the portion size. Idlis have carbohydrates, 2 idlis means 2 idlis. 1 small katori of rice is 1 small katori of rice. She can't have a huge amount of carbohydrates. Proteins are good because they'll take 3 to 5 hours to convert into sugars. So 50-60% of it gets converted to blood sugar, which is okay for the body to handle. Fats, less than 10% get converted to sugar. So a spoon of ghee is still quite okay. The 5 points, 5 minutes is all that you will take. Reduce the grain size. No going beyond 2 idlis, 2 dosas, 2 rotis, 2 chapatis, 1 small cup of boil of rice or upma or poha. Easy to say because you want small amount of carbohydrates. You must tell her what are the sources of proteins. You tell protein is very good, but what does it mean to her? Paneer, soya, dals, lentils, sprouted chana, vagere, and boiled groundnut, nuts, seeds. But if she's a non-vegetarian, then egg, chicken, small fish, and milk. Frequency of meals. Every time she challenges the body with little sugars, body can take the challenge. 3 small meals, 5 small snacks, and fixed time for all meals. Avoid bakery items, avoid packaged food. In between this, pregnant women feeling very hungry, take roasted chana, nuts, seeds, cuts fruits, salads, puffed rice, buttermilk, homemade traditional salads. There is a plenty of variety. Actually, it looks as though these GDM patients keep on eating all the day, but each time they eat small portion and the right kind of meat. Eat right is the mantra. So when she does all this, you give her 2 weeks time because you have to drill it into her head exactly. She should understand what it should. Then you will meet the targets. Now, less than 95 and the fasting or before meal. Then at 2 hours after meal will be 120. 1 hour after meal is 140 or less. These are the targets to meet, and HbA1c will be far less than 6 gram%. So pre-existing diabetes also, gestational diabetes also, hyperglycemia in pregnancy should become euglycemic. From high sugars, you to bring her to normal sugars. Sometimes the time range targets are there. At certain points in the day, the sugars will be rising high. This is easily now detectable by the continuous glucose monitoring by Libre, but we are going to get in new imported devices called Vizmi from Israel, which is just like a bangle. There's no prick nor poke, and continually it will monitor the glucose. You give it to the patient for 1 week and you can recognize how her sugars are going up and down. This is now most important. Please involve the family in the discussion. Otherwise, you tell her, she'll nod her head in front of you and go, the people at home or The mother-in-laws and mothers of the world will say, no, you need to eat for 2 people. You're not at all gaining much weight, and they psych her up and confuse her totally. So if all are involved in your team for discussions, it is always better. Weight gain has to be restricted between 6 to 8 kilos. 1 or 2 kilos she loses in the middle also, it's not an issue, because she has to restrict her overall calorie intake. Normally we allow 10 to 12 kilos of weight gain in pregnancy, but here it's only 6 to 8 kilos. Lot of work that she has to do. Preeti was mentioning that I was involved in the FIGO team for setting the guidelines, and when we put this picture, the central picture of Jhadu Patka, none of the FIGO members could realize what is she doing, so the cultures and the social fiber of each country is so different. So when you tell exercises, you should know what you're talking about. Here again, find out her daily pattern of work, and upper body exercises and brisk walk, etc. are extreme, because once you say she's at high risk because of hyperglycemia, high risk means bed rest. That is what the signal normally it alerts in their mind. So please tell, in this situation, exercising is equally important as the diet control. So once you do the universal testing, say 10% of your pregnant patients have high sugars. First is the medical nutritional counseling. With this alone, if you've done it right, then 80% will come under control. The last 20% who do not fall in line with this anyway will continue the diet and exercise, but also they will need metformin or insulin as a part of their pharmacotherapy. So a huge list of confusions of BMIs and matching this, that, and all. Please don't confuse the patient and confuse yourself. Just tell her, now Shield Healthcare itself had distributed the GDM plates, because if she gets a plate with the correct kind of foodstuff printed on that, it's very, very easy for her to just see the plate and put the right things like fruits and vegetables and small portion of carbohydrates and lots of dals and sabji and sambar and stuff like that, and some bit of the dairy products, and she's covered for the appropriate food that we want. When we say low glycemic index, it means that when you eat it, suddenly your blood sugar doesn't shoot up. The glycemic index relates to how soon whatever you eat gets converted into blood sugar. Like the gulab jamun will get converted quickly, whereas the apple that you eat will not get converted quickly with the skin, especially if you eat. So avoid over restriction, because some of the family members are so kind of frightened to give her anything at all. They really make the patient starve, and we have found real loss of weight and growth restricted babies, even though the blood flow is normal. Oftentimes hyperglycemia has pregnancy-induced hypertension also as a comorbidity. So if the blood flow placental insufficiency is there, they can grow less, but purely because of inadequate diet also, she can suffer with restricted growth. Metformin, again, it's a very common prescription, a friendly prescription for the OBGYNs, because it's not like Acarpos or Glargine or other types of unheard of names, which are anti-diabetic tablets. Metformin is very familiar to us. We anyhow use it in cases of PCO. You can continue till 12 weeks. There's a small gap in literature whether you can continue to use it between 12 and 20 weeks. But after 20 weeks, mid-trimester, if you're diagnosed, certainly diet and exercises, and the next line of attack will be by metformin. Again, your targets of sugar should be met. 90 or 95 in the fasting, 122 hours post-meal. So these are all the colors which are shown for the different types of insulin, which also indicate the peak timing of their action. For example, the Ditimer, whatever time you're giving, it will only start its peak action in about 6 hours time. So when it goes to the insulin stage, let's not be over smart and too wise. It will be good to take advice from the diabetologist on the phone, at least, to say that this is where we have landed and we have very little time for delivery. So we need a tight control. So kindly guide us about the insulin that we should be taking. managing GDM is not only managing the mother and child with the glycemic control, as I have just alluded to. It's also about managing the coexisting anemia, undernutrition, PIH, polyamnios, inappropriate weight gain, preterm labor, maturity of lung is delayed. There could be high chance of congenital malformations if it's not well controlled in the early part of the pregnancy. Then you got to finally decide about time, mode, and place of delivery. So there's a lot beyond the sugar control, because in the second trimester, we usually get not only this is a little early anomaly scan, because anomalies are common, so you might as well rule it out at the earliest. And the color Doppler, again, because the blood flow is usually not an issue in diabetes, but it's an issue in PIH. If it's a chronic diabetic with vasculopathy, then of course the Doppler flow will be limited. Fetal echo also, it's better to get it done at 22 to 24 weeks because cardiac anomalies are quite common. If the uterine artery Doppler shows a change, then aspirin needs to be added. Abdominal circumference is where your eyes will go when you look at the scan report. If it's more than 90th percentile, then there is macrosomia. Your control needs to be much, much more tighter. Don't hesitate to give the corticosteroids if you're suspecting a preterm, and the standard 2 doses or 4 doses, whatever you give. But beware that this will increase the sugars further. So you have to monitor the sugars consistently for 48 hours after stopping the last dose of steroid injection. The timing of delivery, please, please, please let her not go beyond 40 weeks. 38 weeks, you are on the alert, especially if she's had a previous stillbirth and other nephropathy, vasculopathy, poor glycemic control, these kind of situations are there, then you should not hesitate. 38 weeks is good enough maturity. And if you're given the steroids, definitely lungs also will be mature. Please pull this baby out. Fetal macrosomia is a challenge because many times the ultrasound will overestimate or underestimate the weight. Many old-time clinicians will still see the head size and the abdominal palpation and then try to guess whether this will slip through easily or not. But more often than not, if the baby is a little large size, then the mode of delivery is a liberal policy towards C-section, because our babies, which are 3.8 to 4 kilos, very, very difficult to deliver from Asian Indian structure of the pelvis. If you get landed with shoulder dystocia, say, I knew this will happen. Okay, but you can never predict. Okay, so you are not even conducting the drills in the non-crisis times. So nobody is experienced in pulling out this baby and the shoulder gets stuck when stuck. All the meticulousness with which you have controlled the sugars and paid attention to all the micro details will go into the thin air. So one clinical leader to make the decision, coordinated activity, don't confuse yourself and the patient by different members in the team talking, nahi, ye bhi ho sakta tha, wo bhi ho sakta tha, etc. Vaginal cervical injuries, anal sphincter damage, operative difficulties, injuries to uterine vessels or bladder, hemorrhage and hematomas. These are all a package with the GDM. So you may have to be ready in your mind for blood transfusions, anemia management, when the fistulas and incontinence, God forbid, because of these array of problems, it's very traumatic experience for the obstetrician too. If she presents in spontaneous labor, if she is a case where you have controlled her entirely with medical nutrition therapy or at the most the metformin, admission CTG, partogram, monitor the blood glucose 4th hourly, maintain the target levels, continuous fetal monitoring, and she can deliver vaginally. Sometimes we post for elective sections in those patients, like previous section, she's landed up with GDM this time. Then you want to do an elective section. Nil by mouth, omit the morning dose of insulin, do her fasting sugars and electrolytes, post-op also meticulous sliding scale therapy with insulin should be given and sugars monitored. So neonatal hypoglycemia is a real challenge because just give me a minute. there was some loud noise outside. So I wanted to just make sure things are okay. Neonatal hypoglycemia, because this baby is used to be in a luxury compartment with a 5-star meal with rich sugars. And soon after birth, it will expect the same. But it cannot feed so adequately in the first 24 hours. So though we always, Sneha knows about it, initiate breastfeeding within the first hour after birth. And there's a lot of support that we give for breastfeeding. However, the sugars of the baby need to be monitored at 30 minutes, 1 hour, 2 hours, 4 hours, 8 hours, and 12 hours. Anytime the baby is lethargic, glucose water sometimes is given. Pediatricians will advise, please bring it to their notice if any such minor flaws are there. Cerebral palsy, epilepsy, a cognitive impairment, visual problems, developmental behavior disorders are long-term problems with neonatal hyperglycemia. So don't let that happen to your baby, right? The last thing I want to say, prevent the progression from DIP to DAP. What is DIP? Diabetes in pregnancy. What is DAP? Diabetes after pregnancy. So forever after, you must be after her to see to it that she does not develop diabetes after pregnancy. That will come by annual testing, continually motivating her for a better lifestyle. In fact, that should be started in the generation next. We are walking towards tomorrow. More is said about lifestyles, but less is implemented. So bring it to the already health conscious next generation that they have to align with some of the advices for diet and exercises. Many have taken to it. Please encourage them, motivate them to continue at any given opportunity that you meet them. Appreciate the efforts that they're taking to make a change in their lifestyle. Finally, I would like to end saying that all these may seem overwhelming, because how do we reach every girl, every woman? How do we get in touch with so many dietitians, so many diabetologists, so many specialists? It's a multi-stakeholder, multi-speciality issue. Large burden rests on your shoulders. How do you connect with the others? Yes, the digital platform is there, like how you and me are connecting today, and we exploit that to the fullest and make use of this innovation. As my theme a decade ago went from innovation to implementation to make the impact. So thank you so very much for the opportunity, for helping us manage the GDM pre-pregnancy, during pregnancy, and beyond pregnancy forever and forever. This sweet company will always be cherished and remembered. Thank you.
Thank you, ma'am, for nicely elaborating the subject. With good nutrition, diet, exercise, and medicine, we can control. And we can also take the help of diabetologist or endocrinologist to control GDM, and liberal use of cesarean in Indian mother to save mother, baby, and doctors too. I request Dr. Kirtan sir. To continue.
There is one question in the question box, one Dr. Harish Udwani.
Yes, Sharu.
Yes, he has asked a question. If the
postprandial, the post glucose to our blood sugar level is 210, and on next day, if the fasting blood sugar is 87, postprandial is 117, then should we give metformin? That is what the question. So, madam, for your
usually what happens, so usually when we change the track from diet and exercise alone, we want to step up to metformin. It's not decided by one random reading on one information that we get. If the meal on that day has been a little haywire, in fact, so many of our clever patients, when they themselves see that, post meal has gone, they'll say, I had eaten this, that, and the other, and therefore I didn't walk today after my lunch, and therefore this has happened. So they figure it out for themselves. So if the next day's fasting is fine, post meal is fine, then there is no need to rush and give the metformin. 2 more days you ask her to monitor. Usually how we tell in practical terms is, we give her a glucose monitoring sheet. Nowadays they are putting on their mobile only. Generation X has got 2 digital savvy and 2 clever. So one day if they do fasting, next day they'll do post breakfast, next day post lunch, next day post dinner. Then again they come back to fasting. So when they come after 2 weeks, we just have a complete glance on where it is going wrong. So that is where how we decide the next edition of metformin. And metformin also slowly, when you start from 500 mg, once a day, twice a day, it can go up to 3 times a day. And if it's still fluctuating, then it's time to just give a call to the diabetologist. But make sure that your diet advice has gone into her brain correctly, and also make her write her diet with really whether she's taking so many frequent small meals and whether she's taken these items for the snacks. One glance and then you know what she's doing or what she's not doing. Once in a while, of course, she's allowed to cheat, but mostly if you guide her through. In pregnancy, especially, they're very, 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 very well behaved. They will listen to us. So use that to your advantage. As I said, 80% can be controlled with MNT. Yes, the next thing is to add metformin. But if you get a couple of readings which you're not happy with, if you can even call her back in 1 week and just escalate the dose. But too much of metformin, growth restriction, and there are other issues.
Yeah, metformin should. Sneha, can I add one thing?
Yeah. In fact, I was about to.
Metformin.
Just before you add anything, I just clarify what the query is. Actually, we say that once the patient is diagnosed as GDM, then we manage her for 2 weeks with MNT, and then we do her 2 hours postprandial. If that is more than 120, then that is a time to start medication. So what I can see here, that the initial response itself is the blood sugar level is 210, the post glucose. So whether a blood glucose level of more than 200 requires or directly to go for medication, and whether it should be insulin or metformin. I think that is that would clarify.
Okay, if you Preeti, just give me a minute. So if this question is rephrased like this, the initial pregnancy is it's a limited edition. It's a limited time span. We don't have so much time whole life to control her. So if the initial readings itself is like that, okay, you do the testing, single step, it comes positive, then you do the fasting post meal, and then it's over 200, then you cannot wait too long to start the medication. You give the diet advice, that is a given, it has to be a foundation. You add metformin, and when you add any medication, this meticulous monitoring of the chart, home monitoring is a must. So when you see that many values are coming really low, then you need to rethink whether this metformin should stay or you should withdraw it. There is good chance that metformin you may have to escalate it also, because if at 200 is very, very likely, then you always almost do a HbA1c, because suddenly it wouldn't have become 200. It would have been quite hopeless in the last 3 months also. So all these triggers your mind for management, which is more judiciously. You have to apply your mind, spend some more time, mix and match and individualize, and you need to reassure the patient that sometimes this happens, but then we'll get you back on track, and you must show her that yes, she has done well and she's come back on track. So that's the way, because these patients get very depressed if you kind of scold them that you haven't stuck to the diet pattern, and then see how hopeless your sugars are. That should never be the approach. So counseling very softly but firmly is really very important. Preeti?
Thank you so much. I think Preeti, from your side.
Just few comments. I think Dr. Hema has already covered this question. Few things I want to emphasize here, that metformin should not be given in any cases of placental insufficiency like IUGR or preeclampsia or whatever. The second thing is, again, I always tell, it is not the sugar levels that decide about the treatment protocol. It's always the obstetric outcome. Like if suppose the patient comes in early trimester or first trimester, and you find the sugars between 200, 250, you have to add some oral hypoglycemics. You cannot wait, because otherwise the patient might land up in congenital malformations and all. So you have to add. I showed you in the chart that anything above 200, most likely these are patients of pre-existing diabetes. Already they had diabetes, which was detected.
I think some network issues.
Frozen.
Yeah, frozen. So I think that should be all. It's a very good discussion, madam. Excellent deliberation as always. Thank you so much for accepting our invitation and wonderful talk. We enjoyed thoroughly. We are going to have the panel discussion also. For this, I will hand over this to Dr. Kirtan Bas. And we also have few cases on GDM and other medical disorders as well. Over to you, Kirtan.
Thank you, madam. So for the panel discussion, I would like to invite none other than Dr. Sneha Bhuya, madam. And it's really an honor to invite Dr. Sneha, madam, always smiling, always very cooperative, and she has to her credit so many laurels. I would like to mention a few of them. She is an MBBS and MD pass out both from the prestigious BJMC Pune. She is the managing director of her Sukhkarta Hospital for like more than 29 years by now. And she also has teaching experience of more than 5 years. She has to her credit more than 300 talks in state, national, and international conferences, and more than 25 articles or chapters in national publications. She is also a peer reviewer of Journal of Obs and Gynae of India. That's our own Foxy journal. She has been awarded with so many individual awards and accolades from Foxy and also from different organizations all over India and around the world, including the Champions of Foxy, National Expert in UNICEF. She has been a lead assessor in Foxy Manyata project. She is also the recipient of Anandibai Joshi Award by the government of Maharashtra in 2005. She has also been awarded the Foxy President Appreciation Award for Public Awareness in 2018. And she has to her credit so many conferences.
Thank you so much, Kirtan.
Yes. And our best wishes with Dr. Sneha, madam. I request madam to invite all your esteemed panelists for a healthy panel discussion.
Yes, thank you so much. Saiti, I think you can stop sharing. Without much ado, I would like to go ahead with the panel discussion. I think we will focus more on the academic discussion here. And I would like to welcome my esteemed panelist, Dr. Jigna Ganata. Welcome, madam. Madam is the past secretary of Rajkot Society. Dr. Jayesh Solanki. Do we have Dr. Jayesh Solanki, who is the past secretary of Jamnagar? Dr. Madhav Hirani. Hello, Dr. Madhav.
Hello, ma'am. Hi, good evening.
Yeah. So Madhav is the secretary of Rajkot Society. Dr. Bhavik Khatri is the secretary of Bush. Hello, Dr. Bhavik. Hello. Yeah, hello. So Dr. Deepen Parekh, who is the joint secretary of Jamnagar Society. Welcome, Dr. Deepen. Dr. Dharmesh Patel, who is the secretary of Rajkot Society. I think we have some doubling of the post here, but yes, I welcome all of you for this panel discussion, and I'm sure this will be very, very helpful as practicing obstetricians and gynecologists. We're going to have a very practical discussion here. So we start with our case scenarios. We start with Dr. Jigna. Madam, we have this third gravida para two living issues. In spite of this, now she has 3 months amenorrhea and she insists on continuation of this pregnancy. She comes to you with complaints of weakness, easy fatigability, and breathlessness. There's no complaints of pain or bleeding. Her vitals are stable. Abdominal examination reveals no abnormality. When you do her basic hemoglobin levels, hemoglobin is 5 gram%. So what is your diagnosis at this point of time, and how would you like to investigate and manage this patient? Dr. Jigna. Yes,
Yes, madam.
yes,
Good evening,
please.
all. First of all, I heartily thank Dr. Sneha madam and all other organizers for inviting me as a panelist for today's very interesting and academic session. So regarding this patient, she is Gravida 3 Para 2 with living 2. And her seeing her hemoglobin 5 gram percentage and with her complaint of weakness, easy fatigability and breathlessness. She is a case of severe anemia with pregnancy. So other investigations which I would like to advise her is we have only the report of hemoglobin. So I will get her the count. CBC with peripheral smear also I will advise her. Then reticulocyte count and in the complete blood count CBC we get all indices also, that is MCV, MCH, MCHC and RDW, from which we can decide that whether this is hypochromic microcytic RBCs are there or not. And other investigations which I would like to advise are from CBC only we can see WBC count, platelets, cell morphology also we can see by peripheral smear. I would also like to advise, as I am working in a corporate hospital where we can advise investigations for any bleeding disorders. That also I will definitely advise coagulation profile. I will get her done her liver function test, renal function test. Also, I will advise her sonography abdomen. Also, I will advise for liver and spleen. Because 3 months of amenorrhea is there, pregnancy we see, but liver and spleen also we have to see. And stool for occult blood also I advise. And after that, along with this, iron profile also and ferritin level especially also I will like to advise.
Yeah, so my question to you, Dr. Jigna,
Yes,
if you
madam.
have all this information and suppose the peripheral smear is showing iron deficiency anemia, this patient has got severe anemia which is symptomatic. So what would be your preferred way of management, and whether you would like to go for iron profile? What is the reason for this?
Yes, madam. Iron profile I will definitely do depending on the serum iron, TIBC and ferritin level. If ferritin level is low, then definitely that will help in deciding the line of management. If patient is symptomatic, means she is having severe weakness, breathlessness and all, then line of treatment will be blood transfusion. But if patient is
Asymptomatic.
if patient is asymptomatic, only the report is showing anemia, then I will advise her two things. If she is very compliant in taking oral iron, then I will give her time.
Do you feel that during third month of pregnancy, whether she will be having some problems with iron preparation, oral iron? And
Yes,
do you
madam.
think that whether you should start directly with iron treatment? What is
See,
your
madam,
explanation?
madam, all the patients may not be having nausea and vomiting.
Correct.
Already she has reached to 3 months.
Agreed, accepted.
And if she is not keen for taking injectables, means
Yeah.
she is fine and she is compliant in taking oral medicines, I will first give her time for at least 1 month in regularly if she is taking oral medicines.
My next question to you is only with the microcytic hypochromic picture on peripheral smear, whether you would like to give her the iron or whether you would like to investigate and rule out some of the problems. And
Yes,
what
I
are
will definitely investigate. I will see ferritin level also. And hemoglobin electrophoresis also I will advise her
Yes,
definitely.
that is what the message is, that even though on peripheral smear, the picture is of microcytic hypochromic anemia, which is very, very suggestive of iron deficiency anemia. This patient may be having the hemoglobinopathies, which actually here the picture is microcytic hypochromic type of anemia, but she may actually be in iron overload. So these are the cases where you have to rule out hemoglobinopathies and see that they are not getting iron So unless she has the true iron deficiency, you should not give iron to this patient, especially the injectable iron. Anything else?
Yes,
Yes,
madam.
Dr. Bhavik.
This particular patient has already delivered 2 child previously. If
Mhm.
at all she was suffering from hemoglobinopathies, there
Mhm.
must be history of a blood transfusion during 3rd trimester or after delivery or so. So according
Not
to the
necessarily, not necessary. Some of
Not
the patients,
necessarily.
who are having thalassemia traits, they are having mild to moderate anemias. And over the time, with repeated successive pregnancies and blood loss, she may go to the severe stage. So my next question comes to you once again with this continuation, Dr. Bhavik. What are the stages of iron depletion? Does this patient immediately or as a first case there comes to you as severe anemia, or whether she goes through various stages?
body itself tries to compensate. The pregnancy is, as we know, is the state where the iron requirement increases. So
Correct.
body tries to adapt with this, and the first thing that increases is the absorptive capacity. So intestines try to absorb iron in the larger amount. The second thing that changes is the iron binding capacity increases. So liver also try to produce more proteins that will help iron to get bind in the circulation.
Yes, these are all the
Then-
compensatory mechanisms you are telling us. But
Yes.
my question is whether she comes to you directly or whether she develops directly a severe anemia, or whether she has to go through various stages that initially the iron stores get depleted and
Yes.
then the circulating iron levels fall down. So this is what the explanation, that there is a stage where there is only depletion of the iron stores. So the bone marrow, liver, spleen, all these stores get depleted first. And when you do serum ferritin levels, as Dr. Jigna has very correctly pointed out, then the serum ferritin levels falls. And if they are very low, then of course it's a stage of iron depletion. Now next comes the serum iron levels. The total iron, if it goes down, the iron binding capacity increases, and even the percentage saturation becomes very, very low, then that is a second stage of iron depletion. And third stage, when it comes, when it is clinically evident, then the hemoglobin and the Paxil or the hematocrit falls, and the patient actually starts becoming symptomatic. So this is just theoretical, but yes, you have to know, because you have to catch this patient at an appropriate time and you have to manage her. So naturally the next question comes to you: when should we start screening these women? And why are we worried so much about this? Dr. Dharmesh, can we have from you, are there effects of this anemia on pregnancy? And pregnancy, how does it affect this anemia? Yes, Dr. Dharmesh, please unmute. Yes.
I think you are asking about the pregnancy outcome in case of anemia. I'm not taking your question, ma'am.
Okay, so I clarify once again. How does anemia and pregnancy affect each other?
Okay, sure. Madam, both are, I think, related to each other in such a way that if the baby is there inside the womb, so definitely mother's hemoglobin is going to be decreased. First thing is that. And second thing, if the anemia is there in the mother, then oxygen carrying capacity towards the baby, it's again will be compromised.
Correct.
So in that.
So what are the effects on the body and the baby?
Definitely, it will lead to the some type of anemia, inborn anemia in the baby also, and more HB fall down in the mother also.
Okay.
Right? So body demands always increases in the mother, and as well as in the fetus in case of the anemia. So this will be a thing to investigate more on the fetal side also, whether fetal is having any fetal anemia or not.
Correct. Dr. Madhav, do you want to add anything here? Dr. Madhav or Dr. Jigna? Yes.
I would like to add that there is definitely hemodilution in pregnancy.
Correct.
So if patient is already anemic, the hemoglobin will further fall in pregnancy due to physiological hemodilution. So this will lead to more consequences.
Correct. So basically, because she is already having anemia, because of pregnancy, there will be a relative hemodilution, which will aggravate the anemia further. Her appetite is low, nausea is there, her stomach emptying time is prolonged, digestion is poor. So definitely the intake and absorption will be less. And then of course you have this the postpartum blood loss, maybe whatever blood or hemoglobin which is required for the development of the fetus, placenta, and all the body organs, the postpartum blood loss which you are worried about, and also the lactation, which we should not forget. So definitely pregnancy and lactation increase the demands for hemoglobin. At the same time, on the pregnancy, Dr. Bhavik, do you want to talk about this effect of anemia on pregnancy? How does it affect?
Whenever we talk about pregnancy, it is related to two persons. The one is mother and the other is fetus.
Yes.
The mother in the second trimester may have the various symptoms, that is easy fatigability, edema feet, and cough, dyspnea, and so many other things. And
Yes.
ultimately, if not corrected, may lead to failure, that is cardiac failure. And
Correct.
there will be lots and lots of morbidity. And we know that the anemia is the single most important cause of maternal mortality in India.
Correct.
So you need to be addressed very properly in this particular thing. If in cases of in related to fetus, the anemia will be affecting the fetus as much, and it will be affected in the form of either IUGR, and sometimes there is abruption, and
Yes.
IUFD may occur.
Yes, even the incidence of preeclampsia is very high. The chances for prematurity, the labor dysfunctions, prolonged labor, and of course the operative intervention, postpartum hemorrhage, and higher morbidity and mortality, as Dr. Bhavik has rightly pointed out. So the best time to screen, naturally, the American College of Obstetricians and Gynecologists has said that it should, all pregnant women should be screened for anemia and treated if necessary. But anemia being so rampant in India, almost to the tune of more than 50%, Government of India and Ministry of Health and Family Welfare, as well as FOXI, they have recommended the patient, the woman, pregnant woman, has to be, screened and treated right from the first visit. Then, of course, again at 16 to 20 weeks, 24 to 28 weeks, and 34 to 36. I would go a step ahead and say, why not to plan a pregnancy, go for preconception counseling, or maybe even premarital counseling. And of course, we can say that even the adolescent anemia, which is so very important, we can treat it at that stage. So very well discussed this case, Dr. Jigna. Now we go to Dr. Jayesh Solanki. Do we have Dr. Jayesh here? I can't see him in the panel. Do we have
Madam,
Dr. Jayesh?
yes, Madam Jayesh is stuck with some emergency, so he had to leave.
Okay. So I think somebody else can take up this case. We have this unregistered primary gravida, married for 2 years. She comes to you with 9 months amenorrhea, mild pain in abdomen. She's having fever, cough, breathlessness. When you examine, you find she's got tachycardia and irritable uterus. Suddenly she develops rupture of membranes, and there's absolutely no progress of labor. So you augment her. Still there is no progress. She lands up into fetal distress, or decision for cesarean section is taken. Now this patient, anesthetist examines this patient and finds a very prominent grade 4/6 diastolic murmur. She was taken up for cesarean section, regional anesthesia was given, baby delivered, but suddenly the patient became severely breathless. So what do you feel your diagnosis is, and could this have been prevented? So Dr. Deepan, do you want to take up this case?
Yes, ma'am. She might develop the congestive cardiac failure because of the postpartum shift of fluid from the fetus to the mother. Secondary to the underlying heart disease, which might be might be the mitral stenosis.
Okay, because it's a diastolic murmur. Until now, she has not had any symptoms previously. She was not diagnosed. So what can be the, what are the various types of heart disease, and what is the grade of this, or NYHA classification of this case you would think of?
NYHA classifies the heart disease in the four classification. Class 1 is there is no aggression on to the patient while doing the routine activities. Class 2 is there is no symptom at rest, but patient might get exacerbation of symptom during the routine activities. Class 3 is when the patient gets breathlessness or having symptom on less than routine activity. And the class 4 is a patient has a symptom at rest. There is no activity. There is no activity like patient can do without any exacerbation of the symptom.
Yes. So suppose if this patient was diagnosed previously as heart disease, this patient could have been at what grade or what classification, and whether she is a high risk or which category she belongs to as far as pregnancy is concerned.
But it's a medium risk patient as a mitral stenosis has a that not much implication on the pregnancy if the patient is follow the routine medication and routine protocol.
Okay. So is there something called as what is critical mitral stenosis? What should be the orifice?
The diameter of mitral valve is around 4 centimeters square normally. When it is to less than 2.5 or less than 2, it is critical mitral stenosis. When the patient is developing chance of cardiac failure is quite more than the normal.
Correct. Very true. And now last question to you, Dr. Deepen. What are the cases of heart disease where you actually ask them to avoid pregnancy? What are those?
There are very few, like primary pulmonary hypertension, Menger syndrome, which is quite a high mortality, around 40% of mortality during the pregnancy. So better to avoid pregnancy by using contraception or do the termination if they get pregnant incidentally.
Correct. Aortic coarctation with valvular involvement, and of course Marfan syndrome with aortic involvement. These are few more conditions. So these are the 4 conditions where you have to actually strictly avoid pregnancy. So this case has rheumatic heart disease and most probably a mitral stenosis. It was confirmed on echocardiography as well. So this patient was a medium risk because she was almost NYHA grade 3. And this patient had lots and lots of aggravating factors, like she already had infections. She went into labor, then she went for augmentation, IV fluids, oxytocin, and then of course anesthesia and surgery. So many problems with this patient and aggravating factors. So what are the prognostic indicators for such cases of heart disease, Dr. Deepen?
Yeah, remember the congestive heart failure is a very poor sign for the outcome of congestive heart failure. Then arrhythmia, atrial fibrillation is also a poor sign for the outcome for this patient. And this valvular diameter, if less than 2.5 or less than 2 centimeters square, is also a poor sign for the recovery. We also look for the echo by seeing the ejection volume, ejection fraction of the left ventricular. If it is less than 35, less than 40, is also poor sign for the heart to be recovered.
Correct. So definitely these are the poor prognostic factors, and we have to really keep a watch on this. So what are the aggravating factors? We have already seen she has all these complications, or she has to go through, and these were all the aggravating factors. So what is the effect? I would just ask you, how does pregnancy affect, Dr. Madhav? How does pregnancy affect the heart disease? What is the effect of pregnancy on heart disease and heart disease on pregnancy?
During the anemia, if there is any anemia is there, or if during the pregnancy the workload, the outflow of the cardiac output increases. So that also that will worsen the cardiac status in the during pregnancy, and it will leads to even due to that there will be secondary pulmonary edema secondary to heart disease, which can even lead to infection, endocarditis, and even severe conditions maybe like embolism also can happen.
Yes. Any long-term effect on the basic defect? No. Once the pregnancy is managed successfully, it may not have any long-term effect on the mother per se. What is the effect of the heart disease on pregnancy? How does it complicate the pregnancy?
During if a patient has a heart, if it is known case of heart disease, then even being an obstetrician also, we advise them to be more cautious even sometimes due to heart disease, there might be.
What are the things you want to keep a watch on? Because once the patient has heart disease, you really need to explain them each and everything. What is, doctor, what is the chance of me continuing this pregnancy till term? Whether my baby will be all right, whether the weight will be average, whether the baby will develop a congenital heart disease. So what are your answers to this question?
Definitely, first we have to see for the regular fetal growth, because there are initially that maybe during first trimester we might see miscarriages. Then even the pregnancy continues up to second trimester, we have to see for the any fetal growth retardation is there or not. And during we also have to check for the preterm labor or pre-rupture of membranes. PPROM is any situation like PPROM is there. So these all things are there. Usually congenital this heart disease doesn't have any effect on the baby as per se.
The incidence is not very significant. It is up to the tune of 5% maybe, but that also you have to explain. Yes, Dr. Madhav.
Fetal echo is advisable.
Sorry?
Fetal echo is advisable at 22 weeks of span.
Yes, exactly.
5.5 months. And initially, the best thing will be once the patient is diagnosed or is a known case of heart disease, we have to, we have to label it as a super high risk patient. And monthly, we have to, every ANC, we have to.
Yes. So my question was whether this problem or complication could have been prevented. Yes.
Yes, can be prevented if, as we saw that it was an unbooked case. If the patient was a booked case, then we would have definitely prevent the condition what had happened. We could have diagnosed the patient. We could have even effectively managed. We don't even if patient was a known case, we would have restricted the IV fluids. We would have restricted the augmentation of the labor.
We would have center for initial evaluation to the physician, and we would have kept her under treatment of the cardiologist, right? And we would have given her the prophylaxis for bacterial endocarditis as well, right?
Yes.
And of course, when you are going for the operative intervention, the team of obstetrician, cardiologists, the senior most anesthetists, ICU setup, cardiothoracic, the vascular surgeon, and of course the neonatologist, nursing staff, all this could have been, kept everything ready, and this patient has to be managed in tertiary care center with a multidisciplinary approach. That is what the message here. So registering and getting an antenatal care regularly, finding out or labeling the high risk women, and then going for regular evaluation and treatment, that has to be kept in mind, that it is a need of the hour that all these women are registered for their antenatal care, and they have this institutional delivery, preferably the high risk woman in the multidisciplinary approach. And
I would like to add, madam, one thing, that this patient came in emergency, but she was having complaint of breathlessness.
Correct.
So before taking into cesarean section, for routine cesarean also we do ECG for all the patients. And if ECG would have shown the problem, she was also having diastolic murmur. So before taking for cesarean section, ECG and echo would have been done in this patient even in emergency.
Yes.
That is possible in tertiary care.
Exactly. I totally agree with you. Definitely a physician's opinion should have been taken because she was having breathlessness. So definitely, yes.
Another thing I would like to add, that for each and every antenatal patient, we take BP, we take weight and everything at first antenatal visit only. Auscultation of the chest and heart should be done by gynecologists to rule out cardiac or any abnormal murmur or any sound for each and every patient.
Yes, and any suspicion at any point of time has to be evaluated, and the doubts have to be clarified. If at all any abnormality is present, it has to be notified, and it is to be labeled as a high-risk case. So with this, we go ahead with the third case. And Dr. Bhavik, we have this very interesting case for you. A 22-year-old primary gravida, she comes to you for first antenatal checkup at 10 weeks of gestation. she is 152 centimeter tall, weight is 69, her BMI is 30, and she does not have a family history of diabetes. You have just heard the talks by Dr. Preeti Kumar and Madam Hema Divakar. This is just a revision because we are facing these cases day in and day out. So does she need to be screened for diabetes? If yes, when and how?
As said, now the guidelines say that each and every pregnant patient needs to be screened for gestational diabetes mellitus at least twice in the course of the pregnancy. First is the earliest or in the first trimester of the pregnancy, and second at 24 weeks. So definitely I would like to screen her for diabetes mellitus.
Yes.
Although she is a very young lady, no history of diabetes mellitus, but she is a small, short stature with BMI more than 30.
Yes.
So BMI more than 30 puts her in a little high risk criteria.
Yes,
Also, I would like
but
to
then here I would again tell you that previously we had a risk screening, that is only high risk women used to be get screened. But now the dictum is universal screening, that is every woman during every pregnancy, even if she has become pregnant for multiple occasions, every woman, and if she was negative for GDM in the previous pregnancy, still she has to be screened. So every woman during every pregnancy, and first at the very first point of antenatal care, that is first antenatal visit. So this is what, because definitely GDM has got lots and lots of effects on the mother as well as the fetus, which we are not going to discuss. We just go straightway to the practical management part of it. Should we use HbA1c for screening of GDM during pregnancy? Does it correlate well with blood glucose level? You have the questions, the answers you all know already.
Okay.
Should we use HbA1c for screening?
No,
Very simple.
HbA1c should not be used.
Yes.
It is for
For
only
screening during pregnancy, it is always required. We have to do 75 gram glucose, whether patient is fasting or not. Whenever she comes, we have to give her 75 gram glucose, and after 2 hours, we have to check for sugar.
Correct. So whether she is fasting or no, irrespective of her timing of the last meal, you have to go ahead with 75 gram glucose, single step glucose tolerance test, that or OGCT, oral glucose tolerance challenge test, we would label it as. How do you give? All of you know this. You have to dissolve this 75 gram glucose in 300 ml of water. Ask her to consume over 5 to 10 minutes. Notify the timing, and then you collect her blood sample for plasma glucose level exactly after 2 hours. If they're more than 140, you have to label her as GDM. So here we go ahead with the next discussion. What is the relation of HbA1c with congenital malformation, and how do you correlate blood sugar levels with perinatal mortality? Why are you worried about this perinatal mortality and the HbA1c levels? Yes.
Poor glycemic control in the past definitely brings some of the abnormality, the most common being a caudal regression syndrome. So
and the cardiac anomalies.
Yes. So anyway, the HbA1c when crosses 8, there are high chances of malformations, that is more than 19%.
And if it is more than 10, then the risk still goes higher, that is more than 30%. And here you have a scope for counseling. You will not advise for MTP, medical termination of pregnancy. Here you have to counsel. This is a medical legal aspect I'm sharing with you. You have to tell the patient and the relatives that her HbA1c is more than 10. Her chances for having the baby having congenital malformation is more than 30%, which is very, very high. But the decision is up to you. So you have to take an informed written consent of everything, whatever you have talked to her and the relatives, and let the decision leave it to her. So that is about the HbA1c. How do you correlate the blood sugar levels with the perinatal mortality? Here is a chart. Once again, I have shown that more than 200, the perinatal mortality is to the tune of 35%. And if it is 150 to 200, it is 16%. Around 100, it goes down to 4%. And that is why we have to really, there is actually a need for bringing out these blood sugar levels to these comfortable levels, The fasting should be 69 to 90. Before lunch and dinner, it should be 69 to 105, and post meal should be 120 and not more than that. So this is what about screening I have told you. Universal screening, single step, 75 gram glucose. Now suppose you do this screening, you find that the patient is having GDM. So you have we have discussed this, that you give 2 weeks time, advise her medical nutrition therapy, and after 2 weeks you go for 2 hours postprandial blood glucose level. Now if this is less than 120, the patient is well controlled on MNT, and you have to just advise her to continue with the same, repeat her blood sugar levels, that is 2 hours postprandial after 28 weeks, up to 28 weeks, every 2 weekly, and after 28 weeks, weekly. Suppose this patient's blood sugar level is more than 120, then there is a need for medication. Now we're coming to what medication, and how, Dr. Jigna, would you like to take up this medical nutrition therapy? How do you calculate the calories? How do you advise regarding the spread of the calories?
Yes, basically we have to calculate basically on pre-pregnancy weight and BMI and total weight gain range that we have to find. In previous discussions, they have already told that if obese patient is there, then total weight gain for routine patient we consider as 11 to 12 kg, but for this patient, weight gain of 5 to 9 kg is enough for the pregnancy.
Correct.
And basically, what Hema Divakar madam has already explained, that this depending on the level of activity is also very important. So if patient is having sedentary, then total energy requirement is 2250, and if patient is routinely doing is heavy work, then it is 3200.
Yes. So Dr. Deepan, do you want to comment about this? How do you calculate the calories, and how is the caloric spread or spread of the meal? Yes.
Yeah. The calories calculated according to the work of the patient, work of the client. If it is a heavy worker, like working in the labor class, then it requires a higher calorie, around it is more than 2,500 calorie per day, plus 50 for the pregnancy. If it is sedentary work, like doing the office work, then requirement is quite low, around 1,800 kilocalories per day, plus 350 is for the pregnancy. For the division of the calorie, ask the patient to take more of complex carbohydrate rather than simple carbohydrate. The food which have low glycemic index, more of protein diet, around 10% of the fat in total diet, that we have to advise them. And also try to take a small amount of food. Small and frequent food should be advised to take.
Correct. Very well discussed. So the caloric requirement depends upon the pre-pregnancy weight or the BMI, the weight gain which we have to achieve as per the level of work, whether sedentary, moderate or heavy exercise. And then of course we have to, whenever we advise them the caloric requirement as per their BMI and the level of activity, you have to give them a proper food counseling. Now, what kind of food, as Dr. Deepan has very rightly pointed out, that you have to, otherwise you advise almost 50 to 60% of carbohydrates to the pregnant puppy. So here for this GDM woman, you have to cut short on the carbohydrates. You have to improve or increase on the proteins, that is almost 25 to 30%, and even the fats. Even in the carbohydrates, you have to give the complex carbohydrates and not the simple ones. So that is how, even for the Madam Hema Divakar has clearly told you how to exchange the food items. That is how you have to reduce the caloric intake and especially the carbohydrates. And you have to prefer the low GI foods rather than the high GI ones. And in low GI, you have usually the pulses, the legumes and lentils and nuts. And medium GI, you have the fruits. And high GI is the food which we routinely use, the wheat and rice. So all these things should be minimized. The oats and complex carbohydrates should be preferred. Now, only one point of discussion here is that according to evidence, it says that unless if you have this GDM, you give her 2 weeks time, If the blood sugar level is more than 120, then you have to start medication. So whether it should be, evidence says that insulin should be the drug of choice, the first drug of choice. What is your opinion? All the panelists, I would ask you, and then we go ahead.
I will definitely go
Dr.
with
Deepen
insulin.
and Jigna, yes, all of you. Dr. Bhavik also, three of you
I
can
will
comment.
definitely go with insulin only because oral antihypoglycemic, definitely there is rapid changeover of blood sugar
Correct.
that will be harmful to fetus also. So insulin, we have to convince the patient anyhow. We have to refer to endocrinologist also. If both of us convince them, then it is better for them. With regular glucose monitoring, definitely insulin has to be given to this patient.
Okay. Dr.
Even in
Deepen.
postpartum, even in postpartum period also insulin is required.
Yes, we'll come to that. Dr. Deepen.
Yeah, but I would like to differ Madam Kess. The metformin or gluburide has the same efficacy as like insulin. So OHA has a better compliance that patient has taken easily. There is no need of any injection. No need to titrate the dose by the patient.
We will come to the conclusion.
To start from the OHA.
Yeah.
If it is not controlled by the maximum dose of the OHA, like 2 gram in a metformin or a 20 milligram for the gluburide.
Okay. Dr. Bhavik, your take on this.
Yes, madam. I would like to focus more on the MNT, that is medical nutritional therapy.
No, we are talking about medication now.
Yes,
MNT has to be continued at the background.
Continue with whatever the things are there. Wait till the sugar is 200. If the sugar crosses 200, then I will start with the oral hypoglycemic agents, because I'm more worried about hypoglycemia than
in fact, when the sugar reaches 200, you have to start with insulin. That is an absolute indication for insulin. Dr. Dharmesh?
Yes, madam, definitely. And second thing, I would like to see the HbA1c. If it is on the higher side, more than 8 or 8.5, then definitely we try to go for the insulin, whether glucose level is 150 only. And if HbA1c is in a normal range, then we can start with the metformin in first trimester, early first trimester.
Okay. Right? So let us see what the evidence is. What Dr. Jigna has said is also absolutely correct, because the evidence says that insulin is the most accepted, evidence-based first line of treatment. But what this slide says is management should be in accordance with the available national resources and the infrastructure, even if the specific diagnostic and treatment protocols are not supported by high quality evidence, which is true for India. We don't have, facilities for daily injections. We don't have the facilities for monitoring blood sugar level at the remote places. So there, if at all this happens, then maybe you can use metformin. Let us see what this slide says. The metformin or insulin therapy is the accepted medical management for pregnant women with GDM, not controlled on MNT. Insulin is the first drug of choice, and metformin can be considered after 20 weeks of gestation for medical management of GDM. In cases of PCOS, where the patient was already on metformin and now she becomes pregnant, you can continue metformin. But if the lady is not on metformin, you should not start metformin during early pregnancy. Few more things, as you must have heard Dr. Preeti Kumar talking about the incidence of placental insufficiency and the fetal growth restriction. The chances are very high with metformin. That is also you have to take into consideration. Evidence says insulin is the first line of management. That is what we have to follow. But yes, absolutely, when you have no choice, but something is better than nothing, then metformin can be used. So you are protected because NHM has also accepted this. Now we go to the last case. Dr. Dharmesh, this is a case for you. Second gravida, para-1, previous LSCS, 26 weeks pregnancy, now diagnosed with diabetes during this third month, and she's on insulin. Her HbA1c is 6.5. Her blood pressure is 150/90. Clinically, she's got small for gestational age baby. How to manage this patient?
Madam, overall it is on a borderline on both sides, on the hypertension side and the diabetes side. So we have to carefully monitor about the
Not borderline for diabetes. She is diagnosed diabetes
diagnosed that I understand, but
and on insulin. Yes.
But presently the sugar level is not mentioned.
Yes. So on insulin, she is on this HbA1c. Okay.
So present sugar level should be again be tested, fresh sugar
Yeah.
level.
Yes.
And it is on the normal side, then we can continue with the same management.
Yes. So what are all the risk factors for this patient that we summarize first? What are all the risk factors?
Yeah, definitely. She is with the hypertension also, on borderline hypertension. So she might
Age
worsen
more than 35 years. Previous
Yeah.
LSCS. Diabetic. Hypertensive. And now she's landed up into FGR, or small for gestational age.
Yeah.
Okay. Go to that. So all these problems. Now how to go ahead? What investigations you want to do for this patient? You can enumerate.
Yeah, we have to do for the color Doppler studies again for the
Right from early pregnancy, she's only 10 weeks. Is it?
26
26 weeks. Yes.
Yeah.
She's with you, registered. So right from early pregnancy, what will you do? What investigations you should have done?
Yeah, definitely routine investigation for the first trimester anti-scan, routine blood profile, and quadrupole markers occasionally on the 40 weeks if needed. So since he is diabetic, we should definitely go for the markers also. And all the other investigation, including the hypertension like the urine albumin and serum creatinine also we should look for. And morbidity regarding the diabetes and the hypertension, both should be counseled with the patient.
Okay. And one more thing is, because she's a case of previous seizure, we have to look for the morbidly adherent placenta or placenta accreta spectrum, as we label it as. Okay. So how do you monitor these diabetes? And she's already on insulin. So how frequently you should monitor the blood sugar levels? And what other investigations for monitoring of mother as well as baby? Yeah.
Should be initially she should be monitored with the regular RPS and FPS chart. After 15 days or 1 month,
She's on insulin. She's on insulin.
yeah,
Yes.
she should definitely send. She should keep the sugar level chart again for the first time at the end of the first trimester. We could adjust the dose of the insulin according to that, and if she is fine with some point of insulin, then we have to monitor her every 15 days for her sugar level.
Yes, Dr. Jigna, anything you want to add here?
Yeah, many of the physicians and even endocrinologists give the option to the patient that they put something inside, and that gives continuous monitoring also. So these pregnant patients are more fragile and they are liable for rapid changes of sugar. So this is better. That's what they say, that
Yes.
if patient
And that is
can
why
be
I have mentioned here 7-point testing. 7-point testing, that is 1 very early morning pre-breakfast, and for 3 meals pre and post meal. So say 7-point testing, because on insulin initially to see that she's not going into hypoglycemia and the fetus doesn't suffer, so you have to go for 7-point testing. But once she's stabilized, then maybe every 3rd day you can monitor, or maybe every alternate day. And the target should be fasting less than 90 and postprandial less than 120. That is what. Maternal monitoring, as Dr. Dharmesh has very rightly said, control of blood sugar and blood pressure. Would you like to start antihypertensive here? Let me discuss it here also. 140/90, 150/90.
No, madam, I would not like to start at this level. Again, I will definitely.
Now we take a call on this also, Dr. Dharmesh, Dr. Deepen, whether you would like to start antihypertensive.
Yeah, madam, I would like to add the ecosprin tablet at 12 weeks of scan to reduce the chance of severe preeclampsia in the later gestation. 150 milligram HS starting from the 12 weeks.
She's already 26 weeks. She's already 26 weeks, whether that will help. No.
We can start the outcome.
Definitely, we should start, but whether it will help.
Outcome is
Okay.
uncertain. Yeah.
Yeah. What about antihypertensive? We
If
take
the-
a
if
call
the-
here.
Yeah, if the BPs remain more than 150 systolic or more than 100 diastolic on 2 times in a week period, then we should start the antihypertensive.
Yeah,
medicine.
Dr. Bhavik, what is your opinion on this?
Madam, I will not start antihypertensive here. I will wait for the next visit.
Okay, Dr. Madhav. Madhav was a panelist for my last panel discussion on SDP. So Madhav will know it better. Dr. Madhav, is he here? I don't see Dr. Madhav here. Anybody else? So I would just share with you that
I will go for starting of antihypertensive.
Exactly.
Labetalol,
Yes.
labetalol will be the first line of choice
Yes,
for me.
yes.
Labetalol 100 milligram BD. I will definitely start at 26 weeks if patient has come with me. There is no role of ecosprin because
Correct.
all the placental has been already occupied. So labetalol I will start with regular
Yes.
BP monitoring.
Yes. So first and foremost, what does the evidence says? Your answer is perfect, Dr. Jigna. Evidence says that, NICE guidelines say that once the blood pressure is above 150 by 100 millimeter of mercury, then you should start antihypertensives. But World Justice Organization, FOXI, they say that once the blood pressure is more than 140 systolic and more than 90 diastolic, then we have to start antihypertensive, and the preferred antihypertensive is labetalol. Second is, as far as the role of aspirin is concerned, low dose aspirin is given as a prophylaxis, not as a treatment. Even though you can say that yes, something is better than nothing, but even when it comes to the debate of starting aspirin and its role as protector. So the researchers, they debate on this point, that when should the aspirin start, whether it should be early during pregnancy after 12 weeks or it should be periconceptional. So the most of the opinion comes that it should be preconceptional or periconceptional as soon as possible, because there are 2 waves of the decidual invasion, and we have to start aspirin during the first wave of decidual invasion itself, then only it works. And that is how periconceptional aspirin, that is low dose aspirin in the dose of 75 milligram, will be protective as far as HDP is concerned. So we agree on this point. Aspirin should be started periconceptionally, if not at least during first trimester or as soon as possible as the pregnancy is confirmed. And secondly, antihypertensive, as you have very rightly said, labetalol. Now coming to the monitoring of this diabetes and blood pressure, we have successfully managed this patient, and now she is approaching term. So when will you deliver her, Dr. Bhavi? I would ask you, when will you deliver her? Dr. Bhavi? Yes.
In the case of previous cesarean section and with the diabetes and the hypertension, we have to continually monitor with the fetal Doppler.
Correct.
And as anything goes worsen, then we can terminate, or otherwise.
So what are the criteria for worsening? What is the point of intervention? I would ask you. When will you intervene? Whether you want this pregnancy to reach 40 weeks, 41 weeks, or how?
No, we can wait up to 36 weeks, madam, if everything goes normal. And by that time, at the 32 weeks, we can give the steroids and everything.
This patient is diabetic. Even at 38, 39 weeks, sometimes the baby can land up into respiratory distress syndrome, or what we call it as hyaline membrane disease. I'm sure Dr. Jigna will agree to me. And steroids, what is the significance of steroid? Can you throw some light on this, Dr. Jigna? If you have used the steroids during pregnancy of a diabetic woman, it just disturbs the control totally. The sugar levels shoot up very rapidly.
Very rapidly.
Yes.
For 2 to 3 days, definitely we have to keep a watch on sugar levels, and with the dose of insulin also we have to, for 2 to 3 days, the problem
Yes,
happens.
we have to increase the dose of insulin and we have to monitor very strictly. That's a very reason giving steroid is not the answer. In fact, here it is previous seizure, so maybe our management will differ little, but if everything is fine, all the aspects are well managed and the baby's weight is not much, that is less than 3.8 kg, then what is recommended is that we have to continue this pregnancy till term or whenever she goes into spontaneous labor. That is one. If the baby weight is between 3.8 to 4 kg, then at around 38 to 39, you may just try and induce this patient and can give a trial of labor or VBAC if at all possible here in this case. But yes, large size baby with previous seizure, this is a combination where you can take her for elective cesarean section. But if she was having a previous normal delivery and now diabetic this time and baby weight is 4 kg, that is a time, that is an indication to offer her the elective cesarean section. Now monitoring of the, I think labor, we will not discuss for this patient, but Dr. Hema Divakar has very well discussed here that you have to, monitor this patient. Every hourly blood glucose levels have to be done and it has to be maintained less than 105. And even if at all she requires the insulin, that how it has to be calculated, that we have, if you're taking up this patient for elective seizure, she has to be NBM and that particular dose of insulin is to be skipped. And then of course, post-operatively, you have to monitor the blood sugar levels. If the sugar levels are between 90 to 120, it is absolutely fine. Continue with the normal saline infusion. If it is between 120 to 140, start 4 units of insulin infusion. 140 to 180, start with 6 units of insulin infusion. And if more than 180 to 200, start with 8 units of insulin infusion. Of course, you have to titrate with the blood sugar levels and then start breastfeeding as early as possible. That also helps in improving the carbohydrate metabolism. Our blood sugar levels comes down very fast. The diet has to be maintained. She has to maintain her active physical exercise. She has to keep a watch on her weight reduction, use contraception, which is MEC2, that is, you don't have to use the hormones as far as possible. Intrauterine contraceptive device should be the most acceptable method of contraception. And then she has to go for GCT after 6 weeks and maybe monthly, 6 monthly thereafter. And we have to see that diabetes in pregnancy doesn't continue as diabetes after pregnancy. So that is what the discussion is. Thank you, all my esteemed panelists. Your conversation, your discussion is very, very helpful, very practical, lots and lots of inputs from all of you. And I'm very happy to have all the panelists here, learned panelists. I thank all the societies, president, secretaries of these Rajkot, Jamnagar, Junagadh, Kutch Bhuj societies. And I thank all the respected chief guests, Dr. C.N. Purandare, guest of honor, Dr. Sudhir Shah, Dr. Deepak Bagde sir, of course, my AMOX president, Dr. Rajendra Singh Pardesi, secretary, Dr. Sujata Dalvi, my conveners, Dr. Archana Dwivedi, Dr. Kirtan Vyas, and of course, my MC, Dr. Charu Lata Bape. I thank all of you for having this, having me here, giving me this opportunity. And I humbly seek all your support, wholehearted support for my candidature as Foxy Vice President for the upcoming elections from West Zone. I'm very proud that I belong to your zone and I need your support. And of course, this is a month of May now coming. You'll be receiving a mail from Foxy office, and I request all the president secretaries to nominate me from your society. And for the voting in August, that is 1st to 10th August, ask all your members whom I'm going to request personally to vote in favor of me. Thank you so much. And once again, over to you, Dr. Kirtan.
Thank you very much, madam. It was a wonderful academic discussion. All
I can see
throughout.
Dr. Neeta Sata.
Yes,
hello,
Dr. Neeta
Dr.
madam has lately joined.
Yes.
We welcome you, madam.
Wonderful.
Again.
Yes, wonderful to have you here.
Emergency,
Yes.
so
Yeah,
could join
yeah.
little late.
I heard your talk yesterday and it was wonderful. Welcome to this platform and thank you once again. Over to you, Kirtan.
Thank you. And best wishes to you, Sneha.
I think it was a very academically sound, I would say. We started traveling from hypertension, diabetes, and so many medical disorders. And I think I'll take this opportunity to congratulate everybody as a panelist, but above all, our moderator, Dr. Sneha ma'am. I have been in her panel previously also. I know it is so simplified and very crisp take-home messages. And everybody knows about you, ma'am, but the hard work and the inputs you put into every small thing you do, whether be a talk, whether be a panel, and how you persuade and everybody, you bring out the good things in everybody. That is, I think, is a belief we have in you. And I'll request all the presidents and secretaries who have joined us, delegates, that we should have a very dynamic and academically sound vice president representing our West Zone. So we have our very good candidates sitting in front of us. And I think Madam has named everybody when it comes to vote of thanks, but it's a pleasure that myself and Kirtan have been involved in this program, and wholeheartedly we are with you, ma'am, and thank you for involving both of us. I think Kirtan will agree with the same with me.
Yes,
Any words?
absolutely,
Thank you so
madam.
much, dear Archana.
I
Thank
would
you
say
so much.
that Dr. Sneha madam is friend of all rather. She's
Yes.
ever smiling,
Yes, ma'am.
and whether she is here or she is even traveling even, but she's always ready to answer all our queries. I must say, academically very sound as well as a very good organizational capacities she has. So yes,
So
our best wish is always with you, madam.
Thank you so much, Kirtan. Apart from my so many national and international awards, I prefer to be called as hardcore obstetrician and a passionate Foxian and amoxicillin.
And
Thank
as you
so much.
rightly said, madam, in the beginning itself, that yes, you were the chairperson of the breast committee even, but let the work speaks. So the work you have done for the committee and for the Foxy as a whole is itself a great thing in itself. So our best
truly
wishes with
said,
you, madam.
Kirtan. I was a
Yes.
part of her journey those 3
Yes,
years.
exactly.
So it has been, I
Correct.
mean, both of us rather. So it has
Yes.
been an excellent journey. And we have to do the formality of giving vote of thanks. So I thank everybody. I mean, Madam has named everybody. We miss Dr. Purandre sir, and it was good that Neeta ma'am could join us at the last moment. And above all, the presidents and secretaries, and bringing all these societies together, Sneha ma'am, was a very good effort from your side. And myself
Thank you
and
so much.
Kirtan enjoyed to be a part of this. Rajkot, Junagadh, Bhuj, Jamnagar, and Kutch. And above all, the faculties were so good. We learned so much. Preeti Kumar ma'am, Hima Divakar ma'am. We had blessings from Purandre sir, Deepa Bhagde sir, Dr. Rajendra Pardesi sir, Dr. Sudhir Shah, who is also a very pivotal in everybody bringing out talent from Gujarat. I think we should appreciate Sudhir sir for that. And we are all very happy to have him as a senior with us. And delegates, without whom we cannot imagine the knowledge, the depth we have shared together today. And our media platform, Nishant and Sahiti, thank you so much for being there patiently with us. And it was a very smooth transition platform. Let me thank you for that. As a convener, myself and Kirtan really enjoyed the journey throughout without any technical glitch. So thank you so much, everybody. And we all together seek God's blessings and wish Sneha Madam all the best for her future endeavors. And we would like to see you with us, ma'am, at a different level, which we have already worked, myself and Kirtan. So it would be a pleasure to be with
Thank
you.
you
Over
so
to you,
much,
Kirtan,
dear.
for that.
Thank you,
We
dear.
always
Thank you,
like to
Archana.
see you, beautiful Archana.
Thank you. Thank you so much, Dr. Neeta. Thank you, Dr. Bhavik, Dharmesh,
All the best.
Dipin, and Dr. Madhav. I can see, I think we've lost in between.
Thank you
Dr.
so much,
Jigna
ma'am.
ma'am is
Yeah,
there.
we missed
Dharmesh
you in the
Patel is
last
there.
case, Dr. Madhav. So
Madam,
glad to see.
right from super seniors to all young brigade, all are with you, madam, in your
All are
logic.
Yes.
Yes.
Thank
We
you.
all are with you. All the best wishes.
Thank you so much. Thank you, dear. I will try my best to do whatever creative work I can do for Foxy. I myself being a private practitioner, I will try and do my best. Thank you so much.
Thank you. All the best,
Thank you
ma'am.
once
We all
again.